And so I will really focus on two indications or two time points where radiation and or surgery may be used to improve the survival outcomes of metastatic and non-small cell lung cancer patients. The first is consolidation, which means patients with advanced disease, they get their first-line systemic therapy, they get 3 or 4 courses or cycles. We re-image the patients. They're shown to have just a few areas of residual disease, and then we consolidate or we clear that area of that patient's body of what we can see on imaging. So that's consolidation. The other time point where we could use local therapy in the management of metastatic disease is at oligoprogression, meaning a patient has been on a TKI, for instance, for an EGFR mutated tumor. They've been on it for a year and a half, and then all of a sudden, there's a new site of disease that's progressing. Well, if we radiate that new site of disease that appears to be resistant to the TKI, but the rest of the body is clear of disease, why would we switch the systemic therapy? So treatment of radiation with use of radiation at oligoprogression is another time point in which we could apply radiation to optimize disease control. And what we normally say is that the first treatment that a patient receives is the optimal treatment that the patient will potentially receive. And therefore, we would want to keep the patients on that first-line therapy as long as possible, even if it means that we need to radiate a few areas that represent resistant clones. And so let's move towards consolidation. Again, consolidation is a simple term stating that the patients with stage 4 non-small cell lung cancer receive 3 or 4 courses of systemic therapy. If they continue to demonstrate limited areas of metastatic disseminated disease, then those patients receive radiation. And so the non-small cell lung cancer field has really pushed the forefront of use of radiation in early stage randomized trials. And so the 3 red arrows here demonstrate 3 early phase 2 randomized studies of not a large number of patients, but enough that they all provided a signal that when patients were randomized to either systemic therapy alone or maintenance systemic therapy plus radiation to what's residual after 3 or 4 courses of induction systemic therapy, what we found was that on a consistent basis in all of these studies, the patients that received radiation to the residual disease had a better progression-free survival interval. And we're talking about going from 3.5 months to 9 months on one study, going from 4.4 months to 14 months in another study, and so forth. So they had a profound improvement in progression-free survival when we treated the residual disease after they started systemic therapy. And in 2 of the studies, there was a profound improvement in overall survival. So these studies gave us a signal that perhaps in a larger study, we may see the same results, and this may become a standard of care for advanced non-small cell lung cancer patients that have limited metastatic sites of disease or oligometastatic disease. That's what that term oligometastatic means, limited sites of metastatic disease. And so one thing to note, though, none of these studies were done in the era of immunotherapy. So it was important for us to understand how radiation would help patients who were receiving immunotherapy-based regimens. So that led to this study, NRG-LU002, a randomized phase 2-3 trial of maintenance systemic therapy versus local consolidative therapy plus maintenance systemic therapy for limited metastatic non-small cell lung cancer. And we presented these findings. We presented these findings as an oral presentation at ASCO in 2024. This was the team. It came up with a very large group of wonderful colleagues and collaborators. And so what we can do is we can focus on the diagram on the right here. So basically, we, again, just as a reminder of the basic premise of the study, we took non-small cell lung cancer patients who had advanced disease at diagnosis. Those patients then went on to receive 3 to 4, at least 4 cycles or courses of systemic therapy. And if on repeat imaging, they were found to have 3 or fewer sites of metastatic disease beyond the brain, They were then randomized in a 2-to-1 fashion to radiation to all of those spots of metastatic disease that's residual, followed by continuing the systemic therapy, or they were randomized just to the systemic therapy, no radiation. And we were following these patients for progression-free survival and overall survival outcomes, okay? So we eventually enrolled about 218 patients across 68 sites internationally. And then we had to do an interim analysis, which means we took a break and we wanted to see whether the trial was going in the direction we hoped.